Hey, good morning, everyone. I'm your host, Vic Senese, and welcome to UroNurse. Hey, don't forget to like and subscribe to the show. So we have an interesting dilemma for today. So we're supposed to have Carolyn Zomauer joining us as a nurse practitioner who started her own clinic in Florida for hormone therapy. Join us, but she has not joined the program. So I'm kind of in a bit of a situation where I don't have the guest who's supposed to be on the show. Now, let me explain a little bit about where this happened. So in the past, all the people that I booked are people that I've reached out to myself and have had their information so I can kind of call them up if there's an issue or problem. But as the show has grown and become more popular, we're getting approached by outside booking agents for people and really some interesting, I thought she really would have been a great person to have on the show and some interesting information, especially the expanding role of nurse practitioners. However, what I'm left with is nobody showed and no way to contact her because the only information you get from these folks are their booking agents. And of course, I tried to reach out to that person and haven't heard anything back. So unfortunately, we're not going to have the show, but you know what they say in show business, the show must go on. So I'm going to do my best at kind of looking at what the difference, are in nurse practitioners, what role nurse practitioners are playing. Healthcare has really changed quite a bit, and don't need me to tell you that. I think it's pretty obvious. We've seen a lot of these big changes lately with how healthcare is provided, and nurse practitioners are a key role in this. Now, I also am going to invite if any nurse practitioners happen to be watching the show and want to get on board, just put a comment in that you're willing to come on. I can bring you right into the show and we can have a little bit of a discussion back and forth. But if not, you're going to have to rely on me to kind of lead the way here. So I do have some information I thought I'd start by sharing, kind of some simple breakdowns and where nurse practitioners are falling into the show or falling into healthcare. So let me get my slides up here. All righty. Oops. So let's talk a little bit about the differences in nurse practitioners, where they practice and what type of practice guidelines there are for nurse practitioners. So some of the states have what's called full practice authority. Nurse practitioners can evaluate, diagnose, treat, and prescribe independently. And the states that nurse practitioners in these following states can practice to the full extent of their education and training, often after meeting any traditional experience requirements set by law. And you can see the list here: Alaska, Arizona, Colorado, Connecticut, Delaware, District of Columbia, Guam, Hawaii, Idaho, Iowa, Kansas, Maine, Maryland, Massachusetts. I always have trouble saying that one. Minnesota, Montana, Nebraska, Nevada, New Hampshire, New Mexico, New York, all the news. North Dakota, Oregon, Rhode Island, South Dakota, Utah, Vermont, Washington, and Wyoming. Large number of the states that give full authority for practice. Then there's a second one, which is we call a reduced practice authority. So the nurse practitioner must maintain some kind of collaborative agreement with usually the physician that they're practicing with. And these states, they can deliver many aspects of patient care, but are required to have a regulated collaborative agreement with the physician to provide certain services or prescribe medications. And by the way, most of these nurse practitioners have full prescriptive ability, so they can prescribe. But anyway, those states with reduced authorities: Alabama, Arkansas, Illinois, where I practice, Indiana, where I live, Kentucky, Louisiana, Mississippi, New Jersey, Ohio, Pennsylvania, West Virginia, and Wisconsin. And I can tell you, these are going to be changing laws that we're going to see nurse practitioners picking up more and more. And then there's the restricted practice authority, where they have to have physician supervision. So it's a little different than where they just have an agreement. They're practicing independently, but they're, have an agreement. A physician is working alongside with them. So in restrictive one, nurse practitioners must practice under the physician supervision, delegation, or team management for at least one key aspect of practice, often prescribing or diagnosis. And that's California, Florida, Georgia, Michigan, Missouri, North Carolina, Oklahoma, South Carolina, Tennessee, Texas, and Virginia. So those are all the areas and the differences in practice that we see. Um, Again, for those that join the show late, if you're watching on StreamYard and you want to join the show because you're a nurse practitioner and you have more input than I might be able to come up with on this subject, feel free to put a comment into the comment, and I can actually bring people on to the show. So it's an option out there for you guys, because as I explained, and I see I got a large audience showing up, so that's great. But as I explained, we're kind of stuck that we don't have anybody who was supposed to be here didn't show up. So, and I did get a little comment here. Isn't that similar to a PA practice? And absolutely, Stuart, that's a great point. And I did focus on nurse practitioner because I'm a nurse, but absolutely, the PAs have very similar practice. They have full practice authority, reduced practice authorities, and restricted practice authorities, and are working again, filling in that hole. What kind of led to all this too is interesting. So, one of the things. I want to get myself into a full picture here. So one of the things that I noticed is that myself, now that I become a receiver of healthcare and have to go to different practitioners for different issues, there's just not enough physicians out there anymore. Medical schools didn't keep up with the demand that being a baby boomer, us baby boomers are putting on the healthcare system. So it was inevitable that they would need to have people that could help fill in these positions. And, I think in the most part, when you look at a lot of the different things that physicians train for, they're probably overqualified for what a lot of patients need. They're definitely too busy to spend some of the time that nurse practitioners can spend. So I personally go to see a nurse practitioner for my dermatology. Great person, great nurse, very knowledgeable, explains, spends time with me. I don't feel rushed. I have gone to physicians for dermatology in the past, and similar experience, and able to perform all the same things that the doctor would have performed. So, all right, let's get back to our slideshow here. So, decades of research consistently demonstrate that nurse practitioner-led care delivers outcomes comparable to physician-led care, often with high quality or even higher levels of patient satisfaction. And I do look at a lot of reports that discuss, patient satisfaction. And that's one of the issues I think that nurse practitioners and your PAs, I don't want to eliminate you guys out of this, but again, I hit this. If you want to join me as a PA and on the show and put your 2 cents in, I'll be glad to bring you up. But I have to work from where I'm more comfortable with. But the patients are definitely looking for the extra time that you can spend, and I think that's huge. These are great, especially in my specialty, which is urology. Most urologists are pretty busy in the OR performing the surgeries that they need to perform. The pre-op care, the post-op care, much better handled by their nursing staff. It's one of the things that I did, a lot of pre-op, post-op care. So I think that we can spend more time, and we're focused on that. They're focused on the surgery. So it's all a great thing. And studies across primary care, chronic disease management, and the specialty setting show that nurse practitioners provide safe, effective, and evidence-based treatment while emphasizing preventative care, patient education, and holistic health. Yeah, I mean, that's absolutely the case. Because nurse practitioners frequently spend more time with patients and prioritize shared decision-making, patients often report stronger communication, greater trust, and improved overall experience. In short, NP-led care not only maintains clinical quality, it also enhances the patient-centered aspect of healthcare that drive long-term health outcomes. So, simply said, nurse practitioners are able to provide the same care that you need that you would typically go to your doctor. So let's dive in here a little bit deeper and kind of talk about what's the difference between the education, the training, et cetera, that a nurse practitioner goes through versus your medical doctor. So education, nurse practitioner has to first get a degree in nursing. After that, they go on for a specialty, either an MSN, Master in Science of Nursing, or DNP, which is now the real crux is a doctor of nursing practitioner, plus specialty clinical hours. So they have to do a certain number of hours. And again, they become a DNP or an MS, advanced practice nursing degree. And medical doctor goes to medical school, some as similar as we do in nursing school. And then they have to put in a residency anywhere from 3 to 7 years plus optional fellowships. So it's a longer process to become a doctor, but that's probably why there's less of them than you can get through with getting nursing. Doesn't mean that you're getting less qualified, by the way. I can tell you, I'm a graduate from Rush University in Chicago, had a nursing program and a medical program. I can tell you that the pharmacology course was taught by the same pharmacist that was teaching the medical students and the nursing students. Same exact course. He even told me that. He said, I feel sorry for you nurses. He says, because I only get 1 semester with you guys. They get 2 semesters. And he says, and I don't cut the amount of stuff we talk about. He says, you get 2 semesters worth in 1 semester. He says, so I guess nurses are smarter. All right. So training focus, it's nursing-based, holistic, patient-centered care. I think that's the key difference, where medical is medical-based diagnosis, disease diagnosis and treatment. As I always say, doctors are trained to find problems. Nurses are trained to treat problems. Scope of practice varies by states, as we talked about. Physicians have full independent practice nationwide. Approach to care. Nurses tend to emphasize prevention, education, and wellness. That's why I'm doing this, education. Physicians emphasize diagnosis, treatment, and complex care. They're doing the heavy-duty surgeries. Time with patient. Nurses often have more time for education and counseling. Physicians, shorter visits due to high patient volume. I've seen it in my own practice. A typical day when I started practice with my group of urologists I worked with, and they were working with a nurse and a doctor together, and we were seeing about 30 patients a day. I've seen that number hit 50 or more. Time with patients is what suffers sometimes. Typical roles: primary care. We see nurses in primary care. A lot of nurses are in specialty clinics. As I mentioned, I go to a dermatologist who's a nurse practitioner. Community care and independent practice. Medical doctors, hospital-based care, specialty care, surgery, complex diagnosis. Prescribing authorities, it's always state dependent. Some states require collaboration. Some have full prescribing authority. Docs can prescribe anywhere. They have full prescribing authority. Collaboration. Most nurses work collaboratively, may require some physician oversight, but they can work independently. Often, medical doctors often lead healthcare teams and consult with NPs and other clinicians. And patient satisfaction, finally. High satisfaction due to communication and time spent for the nurse practitioner. Patient satisfaction for the medical doctor. High satisfaction, especially for complex medical and surgical care. So little difference in what you are able to see in the delivery from nurse practitioners to medical doctors. But for patients, that line, I think, is really getting blurred because they're seeing this, nurses and nurse practitioners and medical doctors kind of for the same things, almost interchangeable. One of the things that, sometimes it's just because of the numbers of patients that, the physicians have to see, they kind of refer to this as like physician extenders. The nurse practitioner is an extension of the doctor. So it does allow for better and quicker access for patients. And, let's face facts. You don't need to go in necessarily to see the top specialist when you've just came down with a cold. All right. So nurse practitioners. Now, one of the things with nursing is it's a confusing specialty. There's all different levels at which nurses practice. There was, for basic practice for nursing, there was something called an LPN, licensed practical nurse, which was a high school program. RNs were college educated, but there was programs that were like associated with the hospital, and it was a 2-year program called associate degrees in nursing. Still a registered nurse, had to take the same boards, but only a 2-year program. Myself, I had my degree is in a bachelor's in the science of nursing, so a 4-year degree. And I did an extra 2 years in other subjects. So nurse practitioners, again, as we mentioned, they become nurses first and then go on to take further education. But again, even with them, big difference. You know, the NP, the traditional nurse practitioners, provide advanced clinical care. They can diagnose, treat, prescribe, and manage chronic condition, typically seen in family, adult gerontology, pediatrics, women's health, psychiatric health, and acute care. Then there's something called the clinical nurse specialist. They focus on improving healthcare systems and patient outcomes through clinical expertise, education, and research. They often lead quality improvement, evidence-based practice, and staff education initiatives. Typically see them in cardiology, oncology, critical care, psychiatric, mental health, infection, and care. I do have a comment that came in. I want to share this. I'm an LPN and I didn't pass the RN exam. I rescheduled it in 2 weeks. I hope to pass. Hey, good luck on that. Alrighty. Then certified nurse midwife also provides all the same type of care for low risk childbirth and patient-centered women's health care. Then there's the certified registered nurse anesthetist. Few people know that, but we've had Patrick McCallahan, I think is his last name, who's a nurse practitioner, anesthesia. And he gave a great talk about the fact that nurses were the ones that started anesthesia. Physicians moved in afterwards, but CRNAs are delivering anesthesia and pain management for surgery, labor and delivery, and other medical procedures. They're highly trained in anesthesia administration and patient monitoring. And as Patrick kind of put it, he says, we're the caring ones. And then there's a certified nurse practitioner, sometimes interchangeable with a nurse practitioner. So it does get confusing. And then throw on to that, there's something called an APN. My buddy Jeff Albo is an APN, advanced practice nurse, who has his PhD, and he specializes in sexual health. And if you haven't caught his show on Tuesdays, he's there at 7 p.m. on Dr. Jeff Talks About Sex and Intimacy. So all these areas that nurses are filling in, it really is a growing profession. And I would encourage you, if you're considering getting into the healthcare field, look into this. Let's see. That's my last slide here. So... all right, so I don't see anybody that volunteered to want to come on the show as a nurse practitioner and give me somebody to kind of speak more. But anyway, I did want to kind of talk a little bit about it so that we're not just blowing off a week. Really apologize that we couldn't get that speaker. It would have been great, but lessons learned in life. I always say that you have to kind of figure things out, and I've had a couple of our speakers that came in this way and it worked flawlessly, but I'm going to make a change. I'm going to pretty much, if you want to be on the show, I need to have contact information, cell phone. I can call you up and find out what's going on, because for all I know, maybe she had trouble hooking him to the show, but if it happens, it happens, and you got my apologies. But anyway, I think it was kind of interesting. I do want to look forward to trying to get a nurse practitioner on to talk a little bit about what they do. I think that would still be a fascinating subject to discuss, and appreciate all of you that have come by to watch the show, and sorry for not getting more, but next week we won't have that problem. Fingers crossed, right? But here's what's going to happen next week.
How does nanoknife truly differ from traditional thermal ablation techniques like cryotherapy, radiofrequency ablation, and microwave ablation? In this in-depth educational discussion, Vic Senese, host of UroNurse, is joined by Dr. Brent Sharp, urologist at Northside Hospital, Forsyth in Cumming, Georgia, to break it all down. This episode explores how nanoknife uses high-voltage electrical pulses instead of heat or cold to destroy targeted cancer cells while preserving surrounding structures such as nerves, blood vessels, and the urethra. Unlike thermal ablation, which relies on extreme temperatures and can cause collateral tissue damage, nanoknife offers a non-thermal, precision-based approach that is increasingly being discussed in focal therapy for prostate and other solid tumors. Join us on January 24th at 9 a.m. Central Time to learn more.
Yeah, I'm looking forward to that one because it's really amazing at all the treatments that are coming out for prostate, benign prostate problems, cancer treatments. It's just unbelievable how this area is evolving. And I think it's important for all of you out there to make sure that you stay on top of this because you got to educate our patients on pre-op, post-op, what's going on. So it's really getting to be a complicated place. Let's see. I do have a few comments that came in. I'm going to share. Diane Clower said, "Great job. Excellent information. You are appreciated for this information." Thanks, Diane. Did my best. And Stuart said, "I have found that with the MDs and MPs are now being salaried by the hospital groups and with reduction in Medicare payouts, MDs and DOs have brought this new practice." So yeah, there's lots of reasons that it's happening. I think it's definitely one of them is just shortages. There's just not enough physicians out there. Secondly, I think is the fact that nursing is being appreciated for their education and talent and moving up into the next step. There's been a lot of changes in nursing too. And who you're seeing taking care of you in the offices. Now there's more expansion of the role of the medical assistant and hopefully their education because they're doing more that were traditionally done by nursing, and nursing is moving up to do things that were traditionally done by physicians. I can tell you that the world's going to change. And, I'm always the guy who's talking about AI. I can tell you that AI is going to be the key to all this change because there's been a lot of studies out there that have looked at patients that want to, get that quick access. And Dr. Google is going to be a thing where you call and you're going to be diagnosed over the phone by a robot, AI controlled. The thing is, they're spending time with the patients. They're doing a good job of diagnosing and sometimes could even be better. So who knows? It's all good, but you can always find out more here on UroNurse. And we'll see you next week to learn more about NanoKnife.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.